And we'll get started. So welcome to, let's see, it is Wednesday evening, and we're getting ready to begin our discussion on the neurological system and from the physiologic perspective. And we're going to get started here as soon as I confirm that Melissa can see the screen. Can you see this shared screen, Melissa?
Yes, ma'am.
Okay, great. When somebody's here, I love to be able to confirm that first before just keep going, and it's like, nobody can see a thing. So there's 500 slides. I am just kidding. She's like, oh my God. So we'll go ahead and get started. There's, I think, 17, 18 slides. So there's not that many, but I would hope that this is going to be an interesting and a helpful presentation to discuss our nervous system and how all of it fits together. So as we've done before, this is going to be a systematic approach. We're going to briefly discuss, or not briefly, but we're going to talk about the purpose of our system. And this is the nervous system, of course, how it works normally. We'll talk about a couple common labs, a little bit about pathophysiology, what happens when it goes wrong. And as I understand, you're going to be covering neuro and dementia and some of those issues, which you'll definitely be able to talk about what's going wrong in that case. In this format, I'm also going to talk about the 4 client needs and get us groomed to be familiar with these sorts of classifications of how we look at our patients and how we should be studying to make sure our knowledge is solid as we go through nursing school to be successful on the NCLEX. We'll touch upon 3 common meds and some HESI hints at the end. All right. And when we're talking about the medications, the way that I had discussed them in the past was, of course, the use of the medication. You've already been through some of the pharmacology previously, but for those students who have not been through pharmacology, start thinking in terms of drug classifications. There are fewer drug classifications to learn than there are individual drugs. So my invitation to you is to learn the classifications and 2 or 3 samples within that classification, and you will be amazed at how much information you can actually learn and retain. So you want to know the use of why the classification of drug is used, how it works, when you would not want to use it. So contraindications are really important, side effects, nursing considerations, and then, like we mentioned, examples. So just as a quick review, the 4 client needs are safe and effective care environment. This is what we're going to create as good nurses, regardless of what we're doing. Keeping our patients safe is our #1 concern. You will pass the NCLEX if you can do that. If you just are too bogged down in the details and you forget that your patient, to check on your patient and they've stopped breathing or they've arrested and you were too detailed on something else, that would not be good. So safe and effective care, health promotion and maintenance, you want to be able to teach them how to take care of themselves. Never forget the psychosocial aspect. And of course, the physiologic integrity. And that's where we're going to sort of spend most of our time in this format. Consistently through each of our body systems, I decided to use this particular slide as a way of just trying to drive home the importance of how each of the body systems works together to create homeostasis. And that is the goal of all of our body systems. It basically needs to deal with stressors, settle things down, and get back to baseline or homeostasis again. So regardless of what we're dealing with, whether it's a physical insult or a psychological insult or spiritual insult, we all seek to get back to our homeostatic basis. When we're looking at this particular slide, it has to do with how we maintain blood pressure. And in this issue. This is specifically talking about the renin-angiotensin system. A lot of times when we're talking about this, we're thinking, oh my gosh, that's just has to do with the kidneys. But as you can see, it really doesn't. It has to do with not only the kidneys, but the adrenal cortex on the kidney. The lungs have to do with creating some of the angiotensin converting enzyme. Then the kidneys and stuff are reabsorbing things, and they are then either holding on to or trying to excrete fluid to try to maintain the blood pressure. And then the liver is basically where it all starts, where it actually creates the angiotensin, which is basically that substance that is changed through the application of renin to change it into angiotensin 1 that becomes angiotensin 2. Long story made short, how do you think the nervous system plays into all of this, even though there's not a picture of a brain here? And you don't, oh, this could be sort of a rhetorical question, but if there is a decrease in blood flow to the brain, obviously, those baroreceptors are going to pick up on the fact that, whoop, not enough pressure, and then it starts kicking in, releasing the neurotransmitters that are going to basically say, we've got to tighten up the ship, and we're going to have to try to increase our blood pressure. And so that will start triggering a lot of these things to happen, such that it doesn't go directly just from the brain to the blood pressure. It's not like, oh, brain, tighten up everything. It goes through all of these processes to go ahead and coordinate the retention of the sodium in the water, which then will increase the extracellular fluid and will eventually increase the blood pressure. All of this because of why? It sensed a decreased amount of blood pressure in the baroreceptors. It said, ooh, we're not getting enough pressure here, so we're going to have to vasoconstrict. So whoop, starts all this cascade going, vasoconstriction actually happens, and then the blood pressure is actually elevated. I love how this stuff works together. It's fun to track it if you don't get too bogged down in the micro details, other than just knowing that so many different body systems do impact the creation of homeostasis. And again, sort of pinging off of the medical terminology before, homeo means same, stasis means stoppage. So that's where if there's an imbalance, the body is seeking to get back to where there's sameness, same, back to normal again, and it'll stop adjusting things when homeostasis is created. And of course, all the systems need to work together. If one system's broken, then it creates an imbalance, and that can be a problem. So what if, when we're speaking from a neuro perspective, what if the blood can't get to the brain? Or what if the impulses can't get to the muscles? It's like, ruh-roh, things are not going to work right. So from the basis of just trying to understand, again, the nervous system, we'll just take it back to the very beginning with looking at the body system basics. So what is the purpose of the nervous system? It is to make the body have functional ability. It's not just to sort of regulate the system, but to go ahead and regulate the system and to be able to move the body in the process as well, to send the signals out, and to also have cognition and to think and to be able to ponder meaningful things in life. So of course, from the components, the things that are important in our nervous system, our brain, our spinal cord, the nerves, the meninges, and then the cerebral spinal fluid, all of which are important. From the physiological perspective, it is indeed an intricate network of structures that not only activates, but coordinates and controls all the functions in the body. And I always thought that dendrites and axons basically sort of look like little aliens. You know, it looks like, oh, sort of like the alien with really not much of a alien head at the top. The cell body, soma, body, right? And then the dendrites, the parts sticking out, sort of look like trees. And then the axons down below, also, they sort of looks like the body of the the cell itself, and then the legs at the bottom when they're connecting to the other synapses. So when we're talking about common labs, one of the things, especially if you're thinking along the lines of trauma to the brain, whether it's a stroke or a traumatic brain injury, you're going to look at a head CAT CT to assess for stroke and or TBI. And then also PT and PTT if patients need to be on blood thinners. Now, obviously, if they've had a hemorrhagic stroke, meaning there's been bleeding into the brain, we're not going to want to put them on blood thinners, are we? No, but if they've had a clot and have had an ischemic insult to the brain, like a clot has happened and stopped the blood flow into the brain, then they're going to need to be on, they're going to get a clot buster and need to be on blood thinners. And of course, we need to know what a normal PT and PTT are. So as a reminder, I would suggest you get familiar again with your RN notes book, which is the little flip chart book that's sort of yellow and white. And on page 20, you'll have the references for the PT and APTT. And the normal unmedicated level for a PT, prothrombin time, is 10 to 13 seconds. And then the APTT is 25 to 39. Keep those in your memory banks. Those are considered normal. You and me walking around not on blood thinners, okay? So knowing that is important. When we want our patients, however, to be therapeutic, if they're on blood thinners, then those numbers need to be prolonged because we want their blood to be thinner, correct? And so when we're looking at that, we look at if they're on oral medication, say Coumadin, we're looking at the PT, and we'd like it to be 2.5 times the normal, which would put us in the range of, what, 20 to 25 seconds, which looks like the lower number of a PTT. Okay, so just start trying to make some connections. I don't want to confuse the issue at all, but just remember that the PT, normal value, not on medication, in our reference book right now in RN notes is 10 to 13 seconds. And when you're medicating someone and you want them to be therapeutic to prevent blood clots from forming, you're going to want them to be oftentimes 2.5 times as that level, which we use as the INR. We're looking at the international ratio, so that instead of trying to memorize the number of seconds of the PT, you just use 2.5 as the ratio. So we'll talk about that a little bit more as we go along. And common pathophysiologies that we're going to look at again, we're going to connect that back to the client needs and then some medication. So when we're talking about the neurological system, the client need that I chose here from our IGI book, I always call it IGI. I should probably use its full name, Ignatavicius Workman Rebar, also known as IGI, the medical surgical nursing book that we use. And so if you want to turn to 839, and as we've talked about before, the way I suggest that you approach each of the chapters is to look at the learning outcomes at the beginning. And in that, you'll see them broken down into 4 familiar categories, which you can see on your slide are the same 4 big client needs. So I chose number 2, and under that, we would like to identify factors such as risky behaviors or lifestyle choices that place patients at risk for neurological health problems. And when we're looking at those questions or those goals, whoops, I didn't mean to do that. I just lost that briefly. Sorry about that. Okay, here I am. I'm back again. When we're looking at those questions again, the answers or the key points you'll find at the end of each of the chapters in IGI. And for that particular question or that particular focus that we wanted to highlight upon. We wanted to look at reminding our patients that risky behavior that they would like to avoid would be in the area of not doing risky driving behaviors. And so if they're driving, obviously you want them to go ahead and wear their seatbelts. If they're going to be playing football or riding bikes, they need to be wearing appropriate headgear. And these are things that you're like, Ms. Evers, this does not make any sense with physiology. But yes, it does, as it ties into our starting to look at physiology from the perspective of how it impacts our nursing practice. And so we want to go ahead and encourage our patients to avoid that risky behavior, which would be in the category of, not using the proper gear when they're playing sports or going out in cars. All right, so jumping into how are we going to break down the nervous system from the anatomy and physiology perspective? So with most things, it is so much easier if we just divide things up, divide and conquer, right? So obviously we have a central and a peripheral nervous system. The central is real simple, the brain and the spinal cord. So if you look at our diagram here, nervous system at the top, to the right, you have the central nervous system, and that's all by itself. Boop, brain and spinal cord. All right, so that's just going to be like, all right, nice folks, you're just doing the central thing where most of the action is occurring that we're going to be talking about right now. We're going to talk about the peripheral nervous system. And if you recall, it has 12 pairs of cranial nerves. You'll look at learning the cranial nerves later on as you go through the different levels of, or the different adult health classes. There'll be 31 pairs of spinal nerves. Broke that down into 8 cervical, 12 thoracic, 5 lumbar. What did I put? 5 sacral, and that's weird. Okay, and then the coccyx area. Okay, that's interesting. I have to double check. I'm just going to confirm something there with the, I think the bones of the sacrum are broken down, but I always think of that as just solid, but it's, if I recall correctly, it's probably not. All right, earth release. Oh yes, the pairs of the nerves coming out. Sometimes when you read things several times, and this is, I always ask the students to do the same thing. You'll read over things 1,000,001 times and you're like, that doesn't, and you'll then read it again and you're like, it doesn't make sense. But yes, it does, because we're talking the nerves coming out, not specific bones. All right, so anyway, and then the autonomic nervous system. So within there, we have all of the peripheral nervous system, okay? And within the peripheral nervous system, we have the somatic, which again has to do with the body, versus the autonomic. Okay, so when we're talking about the first breakdown, the first category of how it's broken down, nervous system as a whole is broken down into peripheral and central. Okay, central is just the brain and the spinal cord or spinal column. Boom, that's off to itself. Then we're going to take the peripheral and we're going to break the peripheral down into 2 categories: somatic, which has to do with the motor and sensory, and then the autonomic. And that's where the sympathetic and parasympathetic systems come in, okay? So, and we'll talk about each of those. We're going to break them down significantly, and it's going to make a lot of sense to you. So as we were chatting earlier, the somatic system has to do with controlling the muscles and the body's movement and such, and whereas and that you can actually tell your body to do those things. Okay, that's under your own physical control. The autonomic system, however, is under automatic, or the body's self-control. It doesn't need our conscious thought to say, okay, heart rate, speed up. I have stimulated my sympathetic nervous system and I want my heart rate to speed up. Or oh, my vagus nerve has been stimulated and my heart rate is slowing down. All right. So those are not things that we consciously think about. The body takes care of that by itself. So the functions of the nervous system our cognition, we need to be thinking clearly, and that is indeed the most sensitive and earliest symptom of a brain disorder. So when the patient starts like walking and talking and doing fine and being able to think and clearly articulate their thoughts to being jumbled and confused, then you're going to start thinking that there is something going on. So you can have a brain issue as a result of, just not getting enough oxygen to the brain or enough glucose to the brain. So it really doesn't matter what the specific problem is. If the brain is lacking the function, the things that it needs, which is oxygen via the bloodstream, right? That's how the oxygen gets to the brain, or glucose to keep the lights on. Either of those two things decrease, then you're going to see impairment of cognition. All right, and so of course mobility is important, and then sensory perception. All right, so all of those things are the important functions, the main functions of the nervous system. So as we're looking at the central nervous system, if we recall just briefly from the prior slide, there's the brain and the spinal cord. The brain has three major areas, and there's a good picture, just wouldn't fit well on the slide with the words on it. So it's got the brainstem, which basically is the part of the body that is responsible for basic functions that do not require our conscious thought at all, that keep the heart beating and the the respiration. So the life support is as a result of the brainstem functioning properly. And that includes coming up from the bottom, the connection with the spinal cord, the medulla oblongata, the pons, and then the midbrain. That's all part of the brainstem. Then the cerebellum is responsible for the coordination of movements, and that's sort of like at the bottom, the back part of the brain. And then the forebrain is the top, and that's the most advanced section. And so that includes the diencephalon, the cerebrum, which is the largest part that controls the our intelligence and creativity and memory. And then the cerebral cortex, which is part of, again, the cerebrum, which was the higher function, which is like the executive functions and such. And then separate from the brain, not separate from the brain, it's still connected to the brain, but as far as the other piece of the central nervous system is, of course, the spinal cord. And that basically connects the brain with the rest of the body. And so the gray matter is the H-shaped part, which basically is the neuronal bodies, of the cells themselves. And then the white matter is the myelinated axons, which are basically, they have this white lipid sheath. And it's really important to have good, healthy fats, because that lipid fat sheath, thecum, that needs to be healthy and intact. And if it doesn't have an adequate amount of lipids there, then there's a hard time transmitting information, because it needs to get through that blood-brain barrier. Okay, so there needs to be good, healthy fats in our bodies to create a healthy myelinated sheath around our axons. And, they keep doing studies about, why people develop Alzheimer's and all of those sorts of things. And, from years back, it seems that we started seeing an increase in things like Alzheimer's and, early onset of, say, dementia, whether it's Alzheimer's or not. But it seemed to coincide with a time after we started really cutting back on fats in our diets. We went from, eating like all kinds of fatty things, a lot of red meat, a lot of, dairy, a lot of things with fats in them, to this low-fat diet. And if you sort of think about it logically, if we don't have good fats, can we actually have a good, healthy lining of our myelinated areas of our axons in our spinal cord? And could that then have a problem higher up into our brain as well? Those are questions more so than answers. So just sort of try not to fear good fats, okay? Here's the picture of the central nervous system and the spinal cord. And as we mentioned, spinal cord connects to the brainstem. There's the medulla oblongata, the pons, and then the midbrain, also known as the mesencephalon. Okay, mesios means mid, and encephal means brain, so midbrain. Cerebellum towards the back, which is responsible for the coordination. Occipital lobe, which is all part of the cerebrum, the larger part of the brain. This has to do with your vision and stuff comes back from back here as well. Frontal lobe, and then your higher function. Hypothalamus deep within the brain. Thalamus. And then the optic chiasma is here. But if you get hit in the back of the head, that creates problems with the with your vision. All right, and so obviously then the spinal cord and then the spinal nerves and such coming off. And once we leave the spinal cord here and start talking about the peripheral nerves, we're into the peripheral nervous system. And with the peripheral nervous system, we're talking about the spinal nerves themselves. And as a review, we'll talk about the sensory nerves, which we already discussed briefly when we were talking about the medical terminology. And I was very impressed with Melissa because she remembered that the afferent nerves are sensory, and they bring the information to the central nervous system. So they're taking things from the periphery and bringing it into this central nervous system. Whereas the motor nerves are known as efferent, they're exiting the cord and they're going to the periphery, and they're going to actually then tell the muscles to do something. So the afferent are sensory. They're bringing the information from the periphery to the cord to say, oh, what are we going to do? And then the motor nerves are efferent, and they're going out to the muscles. All right. The cranial nerves, there's 12 pairs. And then, of course, well, actually, let me go ahead here. All right. So we've got the receptors coming in, and then I'm going to go ahead and tell the muscles what to do. Motor neurons are, like we're talking about, let's go from the sensory neurons first. Sensory neurons are here. They're bringing the information. The receptors are coming in. These are considered afferent. They're bringing it to the cord. It's going to do all of the communication, and then it's going to decide what needs to be done, and the brain is going to signal what needs to be done, and then it's going to go out the ventral side, the front, and that is where the actual motor neurons are communicated, and then that goes out to the muscles. All right. And then the other really important thing besides the spinal nerves and the cranial nerves are the autonomic nervous system, and that is where fight or flight and the parasympathetic come in. So sympathetic, if you can just remember fight or flight, that is where, you get scared, and then that gets jazzed up and you want to, and then sometimes people will say fight, flight, or freeze, because sometimes you just don't do anything. And then the parasympathetic is that part of the system that slows everything back down to calm, and sometimes we call that feed or breed as well. Okay, so on this particular slide, I wanted to show the breakdown of the where the neurons and such were on the spinal cord and how everything's flowing, in addition to how the actual peripheral nervous system breaks down and where the sympathetic and sympathetic and parasympathetic fit in. So we'll start at the top, and we already talked about the spinal cord and the brain being part of the central nervous system. Okay, so that is in and of itself. Those are in the yellowish and goldish colors at the top. The second part is the peripheral nervous system, which is right below. It's in the sort of turquoise. And on the one side, you have the afferent, and those are bringing the stimulation from the periphery. Afferent, they're adding it to the body. It's coming to the body, to the central nervous system. So there's going to be sensory stuff. If something hurts, you've got a cut. If you felt something pinch, that sensory stimulation is coming in through the afferent system, and that's going to go up to the central nervous system. Or if you have, say, a irritated appendix and you get visceral stimulation, that is going to be like, ouch, pain, right lower quadrant, and that's going to come up to the nervous system and be like, okay, we need to let somebody know about that. Then it's going to go ahead and go out through the efferent division. And if it's a somatic thing, you're going to go ahead, and if you just touch something hot per se, or you cut something, your body's going to say, ooh, let's look at whatever that is. And so the motor neurons are going to bring your fingers up to your face, and you're going to look at what just got cut or pinched or whatever. If indeed the issue is not something that you need to be consciously thinking about, but let's say, ooh, good example, COVID-19, 24/7, we're getting inundated with such cheerful, great information. We're all going to die. I'm just kidding. We're not all going to die. It is an issue, but if you just listen to the news, it seems to me that that seems to be the general message. If you do that constantly, your autonomic nervous system is going to be constantly stimulated. It's going to stimulate the sympathetic nervous system because A, we don't want to die, so we're going to do like this whole fight or flight thing and stimulate our cortisol and epinephrine release, norepinephrine, all of that's going to start getting dumped. And what happens when that happens? When we dump too much epi and cortisol in our system, we diminish our immune system. And so we have to just be careful for all of that. So if we're being stimulated a lot with our sympathetic nervous system, we need to also try to stimulate then our parasympathetic nervous system. Take those deep breaths, because that will help to stimulate the vagus nerve, and then that slows down your respiration or slows down your heart rate and can get things back down to normal. So the somatic nervous system is voluntary, and that is responsible for the motor neurons and the skeletal muscles. And then under here is also the autonomic nervous system, which is involuntary, like we talked about, and that innervates smooth muscle. So for example, sympathetic nervous system is stimulated. The smooth muscles in your bronchi, they dilate, because what you want to do is to be able to get in as much air into your lungs as possible, because you're going to be running from the saber-toothed tiger. And so we're going to scoot ahead to the next slide, and on that particular slide, I think it shows really clearly how that breaks down. So let's just go ahead and compare and contrast the sympathetic nervous system with the parasympathetic. We'll start with the sympathetic because we've been talking about fight or flight, things being stimulated, being frightened. How does that affect the body? So we will think that it's all related to the release of the neurotransmitters. The neurotransmitters common with the sympathetic nervous system are epinephrine, which also is called adrenaline, norepinephrine, and dopamine and serotonin are also in there. So, but the most important ones, the adrenaline, the epinephrine, are that's like the big one. And if you can recall, adrenaline, that ties in with the other fancy name for the sympathetic nervous system, which is also known as the adrenergic nervous system. So if you see something that says adrenergic, it's sympathetic. If you see something that says cholinergic, that is parasympathetic. Cholinergic is similar to or sounds a bit like acetylcholine, which is the neurotransmitter. That is the main neurotransmitter for slowing things down with the parasympathetic. So before we move ahead, I just want to go for the sympathetic nervous system. Think about what your body looks like if you're scared. If you know that you need to run and get away from the saber-toothed tiger, your eyes are going to dilate because you want to take in as much light as possible, to take in as much information as possible. Your mouth is going to get really dry because you're scared, and when you're scared, you're not worried about eating. So if you're not worried about eating, you are not needing your salivary glands, and so that gets dry. If you think about it just from that perspective, you can think that if the sympathetic nervous system dries secretion, what does the parasympathetic do? The parasympathetic is the feed and breed. So it's going to be moist. There's going to be fluids. That's going to be the feel that you get when you're relaxed and you're going to have a beautiful meal. Your salivary glands are going to be stimulated, and they're going to be releasing a lot of good salivation so that you can go ahead and enjoy the yummy food that you're having. So I'll touch quickly, since I'm over here on the parasympathetic. When you think of parasympathetic or cholinergic stimulation, think sludge. Sludge is fluidy, and it is the acronym that means that when the parasympathetic system is stimulated, you're going to have salivation, L, lacrimation, you're going to get tears, urination, excess, meaning that you're going to possibly become incontinent, diarrhea, G is GI stimulation and cramps, and E is emesis. So if you have anything where you've got too much acetylcholine or too much stimulation of the parasympathetic nervous system, you're going to have those symptoms. So if you know that that's what those symptoms are, if your parasympathetic is stimulated, if you take an anticholinergic, you're going to get all of these in the opposite. So instead of a lot of salivation, you're going to be dry. So when the cholinergic system is stimulated, you get lots of fluids, okay? Lots of salivation. Things are thinking about the GI tract being stimulated, okay? Feed and breed, okay? And then if you are blocking that, then everything is going to dry up. Can't see, can't pee, right? Those kinds of things. So this particular slide I really like because you can compare and contrast. So the heart with the sympathetic system, if you're scared, it's going to increase. Your lungs are going to get, your bronchioles are going to dilate. Your stomach, again, when you're scared and you need to run from the saber-toothed tiger, you're not going to be focused on digestion. So that is going to be diminished. However, your liver is going to be like, dude, we need lots of fuel. So it's going to dump glucose into the body. And that is one of the problems that happens with chronic fear or chronic stimulation of the sympathetic nervous system, because the glucose is released as a result of the cortisol dump as well from the kidneys. And when that happens, your glucose levels go up. Kidneys are going to then secrete the epinephrine and norepinephrine, okay? And that's from the adrenal glands on top of the kidneys. The intestines are inhibited. There's not a whole lot of stuff going on there because the focus is not eating or GI stuff. And then the bladder somewhat relaxes, all right? So you gotta just watch out. The bladder can be sort of quizzical as to whether it's going to like drop some urine or not. So that is one that gets a little confusing sometimes, but don't worry about that piece of it. Don't get bogged down too much there, but the urine, I'm just going to, you may leak a little bit of urine because the bladder itself is going to relax. It's not going to be quite as tweaked. So the major nerve that we talked about before in the parasympathetic nervous system is the vagus nerve. All right. And that is the 10th cranial nerve. Let's see. Yes, 10th cranial nerve, earth to me. And that is what innervates and stimulates, innervates it'll go ahead and tells the heart to slow down. The lungs will constrict, the bronchioles constrict, the stomach gets dilated and starts stimulated to go ahead and crank up to receive some food. The liver, instead of stimulating glucose release for fight or flight, is like, ooh, food's coming. So we're going to go ahead and secrete the bile. Intestines bump up a bit, so there's stimulation for peristalsis and receiving and moving food through the GI tract. And then with the bladder, can be a bit contracted because it's holding on to that urine. Okay? There's more urination that's filling the bladder. All right, so I think we've talked about pretty much everything on this slide. My students in the past have found this particular slide helpful to compare and contrast how these are similar, not similar, but how they work in concert with one another to create homeostasis so that the body always seeks to be in balance, not too much or not too less, but always being able to be at a healthy place. So just let me ask you this. Based on what we've talked about, if parasympathetic nervous system is responsible for feeding and breathing, and needs to be stimulated for that to happen, and is basically sort of opposite of the sympathetic nervous system, is it surprising to you to learn that we struggle with GI issues in America when we're under a lot of stress, or GI issues anywhere if we're under a lot of stress? Because if the sympathetic nervous system is stimulated through stress, then our GI system is not ready to really receive the food and to process things, and we get a lot of GI upset. So when it's time to eat, even if we're feeling stressed, it's so much better to take a moment, take a few deep breaths, try to get focused on actually the task at hand, which would be eating, and see about some nice deep breaths and stimulating that vagus nerve so that it will tell the body to go ahead and relax and receive the food. All right, we've talked about what happens when things go well, but what about when things don't go well? So some of the common problems that we talked about, or that are common, that will be discussed even in depth as we move forward through 7 terms of nursing school, are strokes and traumatic brain injury. So strokes can be either hemorrhagic, meaning there's bleeding, or ischemic, meaning there's a clot. So regardless of whether it's hemorrhagic or ischemic, there's going to be ineffective tissue perfusion, right? So whether there's too much fluid in there and you're bled into your brain, if there's too much pressure, you can't, release of oxygen, the flow and the transfer of all the nutrients, all of that can't happen if it's too congested. There's too much pressure. There's not an ability to cross and for the exchange of the nutrients and the oxygen to happen. Also, if there's a blockage and the blood can't even get to the areas, then obviously there's going to be ineffective tissue perfusion from that respect. So 2 common reasons, and that's why we get a stat CAT scan whenever someone's had a change in their mentation. So if you see bleeding into the brain, that would be hemorrhagic, oftentimes is caused by hypertension. So what we would do then, medication class that you would be concerned about would be an antihypertensive med to lower blood pressure safely. And you could choose any of the antihypertensives that you may want to choose. And oops, I Okay, there we go. Or you can go ahead and reflect also upon the antihypertensives that were covered or suggested covering in the cardiovascular system, which were the ACE inhibitors, the beta blockers. The beta blockers slow down the heart rate. The calcium channel blockers are also possible. And then from the ischemic perspective, if there's been a clot that's prevented the blood from getting to the brain, then you're going to typically have a TPA or a clot buster that would be given that would hopefully go ahead and break up the clot and allow for blood flow to get to the brain again. And interestingly enough, about 80% of the strokes are ischemic in nature, and then 20% are hemorrhagic. And then also you could also have a traumatic brain injury, which is a common issue, and it could be anywhere from mild to moderate to severe. But one of the beginnings of a nursing diagnosis would be potential for ineffective cerebral tissue perfusion related to increased intracranial pressure. So if there's too much pressure and swelling within the brain, the intracranial pressure may go above 20 millimeters of mercury. Up to 15 is considered normal. You'd like it to stay less than 20, but if it goes above 20, then you're going to want it. You're going to be treating it. And if there is excessive pressure in the brain, you're going to, of course, be at risk for having seizures. So an anti-seizure medication would be important to be familiar with. Phenytoin is a really common one, also known as Dilantin. There's all kinds of things to learn about phenytoin. That is one of the big ones to focus time and energy on in preparation for NCLEX. The hyperosmolar agents are important as well. Mannitol. One of the important things with mannitol is you're going to put it through a filtered tubing because it has like little crystally things that can happen. You don't want that to get into the system. And then, of course, steroids. Steroids will help with to decrease the swelling. But what do steroids also do? Increase the risk for infection. So it's real important to realize that you're not necessarily going to withhold the steroids, but be careful that if you do give steroids to help with inflammation and swelling, that a secondary side effect is that it could increase the risks for infection. Also, steroids increase the release of extra glucose. And so if you're diabetic, your diabetic patient may become hyperglycemic. So with all of the medications, there is a beautiful time to use them all, but start thinking about what some of the issues, the secondary, any contraindications or things to teach the patient or the family, or as the nurse when they're still in the hospital or in ICU, things to look for so that you can pick up on things early and prevent complications. Again, if you hadn't had a medication format previously, because when I was putting this together, we were looking at students who may not have had pharmacology yet. So I wanted to have a template that you could use to start collecting information. And so as with everything else, you put the medication. The most important thing I would start with is the class. And if you do classifications just as a general whole, and then break them down and list several of the common ones associated within that drug class, that would be fabulous. But learn the general categories first. In your, I believe that everyone gets a handheld, book for the drug classification or drug book, nursing drug reference. And with that, in the very back, it lists the drug classifications. And I always suggest that folks go through that and learn the drug classifications, get familiar with that, and then tease out the individual drugs, or like 2 or 3 individual drugs within each of the classifications. All right. And then finally, in our flow of how we address each of our systems each week, we look at our HESI hints from the red review book, which we're using the 2017, which is the 5th edition. And with that, the key points that we want to recall with working with neuro is to watch temperatures closely, because what happens if that temperature increases, if the patient's body temperature increases? We want to go ahead and lower that and get it back down to a normal level, because if it increases and stays up, it increases the cerebral metabolism and can also, as a result, increase more cerebral swelling or edema. So we don't want that to happen if we have a patient with a TBI or any other kind of neurological problem. Central nervous system involvement is related to the cause of the stroke, whether it's hemorrhagic or ischemic. And so underneath there, the hemorrhagic symptoms are caused by slow, or it could be fast bleeding into the brain tissue. And as I mentioned before, that is often a result of hypertension that's not been well controlled, or sometimes people don't even know they have hypertension until they have their stroke, which is not a good thing. And on the CAT scan, you would see bleeding. So of course, that patient would not be a candidate for TPA or for a clot buster, because they're already bleeding into their brain. You don't want to give them anything that's going to cause more bleeding potentially. So if there's an embolus, however, it's caused by a clot that's broken away from a vessel and is lodged in one of the arteries to the brain and is blocking blood supply. So this is often related to atherosclerosis. And so if it's happened once before, it can also happen again. So it's just, there's so much to learn within the neurological system or the neurosystem. I hope that you have enjoyed this presentation and can glean a few pearls of wisdom as a result. And if you have any questions, we will address those now. And in the meantime, I will stop this recording and answer any questions that may result. Thank you so much and have a wonderful evening. There we go. So hopefully Melissa has not